So good to have you with us, Daniel. I'll go ahead and let you introduce yourself and who you're with.
Sure. Hi, everyone. My name is Daniel Andrews. I'm the Vice President of Sales and Marketing at Reapplix. I've been with the organization for 3 years and part of the executive leadership team.
Well, we're so happy to have you here, Daniel. Could you tell us more about your product and how it stands apart from all the other PRP products on the market?
Sure, love to. So one of the things that attracted me to this organization was just how differentiated the technology was and just how disruptive it could be. And being a 20-year veteran in the advanced wound care space, I saw that the time was perfect for this technology really to find its way into our centers as an adjunct to the already advanced therapies that our providers have available. And so the things that really stood out to me that drew me to this organization was that 3C patch in this category isn't necessarily a PRP. It's actually a leukocyte fibrin patch. It's a physical patch that's made 100% from the patient blood. It's 100% autologous. So what does that mean? It's 3 layers, and that those 3 layers all have a unique benefit for advanced wound healing. Primarily the leukocyte layer. You don't get the leukocyte layer with traditional PRP, and it's that leukocyte layer that plays a critical role in handling bioload, handling foreign material that's in the wound. And it's really that leukocyte adjunct that begins to set the cascade of wound healing as a start of the healing trajectory of the wound. So that was quite unique. And because it's a physical patch, you actually can handle it, manipulate it. It's a physical structure that you actually will use your forceps to place into the wound. You can cut it, you can fenestrate it if you need to. And then in addition to that, the platelet layer, these inventors of this technology found a way to create a very efficient platelet layer for the 3C patch, which captures roughly 98% of the available platelets. And that's not something that you'll get with traditional PRP technology. So that was, something that I thought was quite unique. And then as a physical patch, you also get more of a sustained release of the bioactives as opposed to a gel. Because of that fibrin structure, it's going to be able to deliver those bioactives at a more sustained rate over an extended period of time. And then lastly, I'll share that it's an automated process. And we can talk about each individual step if you like, a little bit more in depth. But with 3C patch, you're drawing the blood. You take the 3C patch device, which is your vacutainer, and you put it into the centrifuge, and you hit start, and you go back to doing what you normally would do during the patient intake process. So it's 100% automated. You're not having to measure, concoct, mix multiple injections and such. You literally draw the blood, put the device in the centrifuge, hit start, and the centrifuge creates the 3-layer patch for you.
Awesome. Well, thank you for that. Kallie and I were talking about PRP and how earlier this year at SAWC there was 2 companies, and then SAWC fall there was 4 companies, and it's going to keep growing, especially with all the big changes in the industry. So where do you see PRP going, and what do you think it's the next big thing? What do you see for the future?
There's no question. I think when we go back to our schooling, right, back to medical school, we're taught that it's really hard to be autologous, and what we've learned in the world of advanced wound care is that autologous is tough to beat. And so but the challenge has always been having something that would seamlessly fit into our workflow that made sense to really implement in the outpatient wound care space, right? And since then, we've been able to create a technology that absolutely can do that. It can deliver an autologous based solution that's from the patient. The patient is the product, and it's hard to beat that, right? But so again, we just haven't had something that made sense that fit into our workflow until now. And so with 3C patch, it was our randomized controlled trial, which played a big part in CMS creating this category. Right? This new category that is reimbursable in the outpatient space. And so, yeah, it has opened up the door for other blood-based therapies, which you're seeing. And yet there's no question it's now possible. It's possible to have an autologous option in your outpatient clinics that makes sense from an operational clinical flow standpoint. And so when you think about autologous versus exogenous, it's a no-brainer. The patient is the product. And so it is going to be the next greatest growth category in regenerative medicine for wound healing.
Yeah, we think so too. Just kind of hearing from all the companies, and it's not a new technology, right? Like orthopedics has been doing it, other areas have been doing it, and so now it coming into the wound care space is really exciting. Let's go back to your product a little bit, and can you share with me how your product's stored compared to others? What are the biggest differences you would say with the other companies that kind of make you stand out, besides kind of your description of the product, but more of like, how do you what do the packages look like? Do you have to refrigerate it, not refrigerate it, things like that?
Yeah, absolutely. No, so it's provided as a disposable kit. It's roughly 6 inches wide and 1.5 inches thick, little box, right? And in that box, you have everything you need for the procedure. It has your needle, it has your needle holder, it has the vacutainer. It also has a little alcohol swab for conducting the venous puncture. And then we also have a little bandage for the venous puncture site. So everything that you really need for the procedure is in the disposable kit. And that kit has a 2-year shelf life based off of date of manufacturing. So it just has to stay at room temperature on the shelf, does not take up much space. But of course, you need the centrifuge, and it's the centrifuge that's really a big piece of the innovation. But here at Reapplix, we provide that centrifuge to our clinics. It's not necessarily a upfront capital expenditure. We keep it really simple for our clinics to make sure that they have access to 3C patch.
Perfect. And then, the biggest hurdle we've talked about, but also kind of knew what was going to happen, is the blood draw. Most of the time, the nurses in the wound care center haven't had to do that in a long time, or if ever, if they were in wound care their whole career. That seems to be the most difficult challenge. Is that something you're seeing? And how are we, or you and other facilities, overcoming that challenge?
Sure. Well, typically their nursing license allows them to do blood draw. It's within their scope of practice. Now, like you mentioned, some nurses that are in wound care and have been in wound care for a while haven't done blood draw in a long time. Some cases not since nursing school, right? And so what we always do is we recommend a blood draw competency refresher, which is something that our nursing teams are familiar with. And typically it's someone within the nursing education department at their partner hospital that can do a refined or an inundated blood draw competency for our nursing team. It usually involves doing a few sticks, maybe shadowing a phlebotomist for a day in the inpatient space. But again, it's within their scope of practice, but it's always just a good, best practice to do a blood draw competency to kind of dust off that blood draw skill.
So talking about, blood draws, things like that, it kind of leads me, into patient compliance. How does that look for, patients that are receiving the 3C patch? What is their treatment schedule, right? Once a week? Are they, what does it look like if they go longer than once a week?
Good question. So just like you would with most other advanced therapies, you're going to have the patient come back on a weekly basis, assuming that their schedule allows this and they're committed to this. It does take a commitment from your patient, right? And so you want them to come every week. And when you look at the evidence, the randomized controlled trial that was done on 3C patch, these patients came weekly, received 3C patch on a weekly basis. And so that's what you really want to do. And you want to have your patients commit to that. Now, compliance. It's greatest challenge in wound care, right, is gaining commitment from your patients to follow the treatment plan. And what we found with 3C patch, and this is anecdotal, that the patient, because they are part of the process, they are the product. They're creating the product. It does open the door for a unique conversation between the provider and the patient about the need to hydrate, the need to, maintain proper nutritional best practices and status, right? Maintain, good blood sugar levels. All of these things play a role in the healing potential of those patients. And I've seen providers where they'll play to that. They'll talk about, we need your help. And if you can continue to show up and you help us in these two areas, watch your nutrition, help with your A1Cs, you may get a better patch, right? They play to that. And we've heard over and over again from centers that we've launched in that they're just super impressed with the patient engagement. We oftentimes find that it's the patient caregiver that's coming along with that patient that just gets really super engaged with the technology, and they start like teaching the other nurses about 3C patch, which is kind of fun. So at the end of the day, I think it's something that makes sense to our patients. It makes sense to the caregiver. We're going to take your healing capabilities, okay, and we're going to just take them out through a very large vein, and we're going to concentrate them down and take your own living cells and your own living healing capabilities and deliver them to your wound.
Yeah, it's kind of been the same across, all of our conversations is that having the patients understand I'm in charge of this, I feel like is making a big difference. So yeah, great answer. I love that explanation. And I love that physicians are, understanding that they can play to that and really make sure that the patients understand that this is them that's healing.
Absolutely.
And so that kind of goes into one of our last questions is dressings, right? Because patients are always going to have, everyone's different. There's going to be more exudate, less exudate. So do you have any, recommendations or best practices for the dressings that cover the 3C patch?
Sure. So the kit actually comes with a primary dressing, and the primary dressing is a product made by Coloplast, and it's a silicone, non-adhesive primary dressing, which is perforated. So it does allow fluid to be pulled from the wound bed itself. But as the old adage goes, if it's a drier wound, we need to add moisture to it. And if it's a wetter wound, we need to pull moisture away. So choosing the secondary dressing based off of how the drainage presents itself is really, really important. So if you do experience an increased output of drainage, then you're just going to want to choose a secondary dressing that's highly absorptive, like a super absorptive dressing. You can also use negative pressure with 3C patch. So if you do have a significant output, then yeah, absolutely use a negative pressure device to help pull that fluid through the primary dressing. You can also use different antimicrobials. There's no contraindication for antimicrobial dressings. So as long as it's not cytotoxic, you're good to go. The last piece I'll add is that it's just, we're at a unique time in the world of advanced wound healing. And so it's really important that you prepare for, any changes that may be on the horizon and look for evidence-based therapy that could be that new tool to add to your toolbox. Wound healing is a very, very challenging science and practice. And so it's important that you have a diverse portfolio of advanced therapies that you can reach for. And lastly, what I'll share is with 3C patch, you should have confidence in the therapy because it is supported by a large randomized controlled trial that was independently led. And it was published in the journal, Lancet Journal of Diabetes and Endocrinology. And there was over 269 patients in that randomized controlled trial. And what they found that 3C patch significantly improved the likelihood to heal over a 20-week period by 89%. So it's backed by a very large randomized controlled trial. And then lastly, I'll add is that because of that evidence, we're very proud that the International Working Group for Diabetic Foot, they actually recommend the use of a leukocyte fibrin patch for the treatment of non-healing diabetic wounds. And there's only one leukocyte fibrin patch in the world, and that is 3C patch. But they do not recommend other blood-based therapies because they don't have the evidence that would substantiate them as it stands today. So something to think about. We are backed by the product, not we. The product is backed by a very valid randomized controlled trial, and that's something that our providers should feel confident in wanting to explore further for themselves and their patient population.
Yeah, definitely. Thank you so much. Again, we appreciate you taking the time out of your busy day to come and talk with us and kind of explain, what the 3C patch is and how it differs from the other products. It definitely, made me realize how you guys stand apart as well. And I know Christina and I both are kind of like have this big like category now of all the different PRPs. Like this one fits here, this one fits here. So Yeah, thank you so much, Daniel.
Well, it was just so great to learn more. And I know our listeners are going to find it valuable too. So thank you.
Thank you, Christina. Thank you,
Yeah.
Kallie. Happy to be here.
Listen or watch full episodes on YouTube or Spotify.